Hi, my name is Dr. Edward Ngwenya, and today we'll be discussing wound healing. Just a basic overview on wound healing. We're not in this session. We won't be discussing the adjuncts of wound healing in detail and the different causes of wound healing. So we'll just touch on the basic process of wound healing. So, what is a wound? A wound is a break or discontinuity in an epithelial lining. We know about the skin, and that the skin differentiates, in fact, from two layers, which is ectoderm and mesoderm. And this usually happens in the fourth week of intrauterine life. A very important structure. In fact, it is the largest organ of the human body. It serves as a protective layer against the external environment, protecting us from UV light, protecting us from bacteria, from fluid losses, protecting us physically from the dangers that are outside, that are external to the body. It also assists us in certain basic measures like sensation. Immunological surveillance is a big part of it, and also just regulation of body temperature. It's important for that, and I think most importantly, it identifies us. It's got to do with aesthetics. It's got to do with identity, and if you can look over the years, and throughout all different nationalities, one of the things that externally distinguishes individuals is the skin. Whether you are dark, whether you are lighter, it serves as some form of identity. Now, the skin we can divide it into two, into thick skin and thin skin. Thick skin is, in the palms of our hands, our soles of our feet. And so it being thick, it means that the layers would be more. Let's just succinctly go through the layers of the skin. Now, on top, the upmost layer is the epidermis. Then you'd get the dermis, and then you get the hypodermis or subcutaneous tissue. Now, the epidermis is divided into layers. Now, the epidermis is a stratified squamous epithelium, and actually it's a layer that continually undergoes keratinization. Now, what is keratinization? It's, when you look at the keratin cells, they become, the cytoplasm rather becomes replaced by keratin as the cell dies and becomes more superficial. So that's the process of keratinization. There are these rete of which are basically epidermal thickenings that extends all the way downward into the dermal papillae that are there. But the structures, there are 5 layers. In thick skin, 4 layers in thin skin. I'm going to give you from the top down. There's the strata corneum, the strata lucidum, the strata granulosum, spinosum, and the base, which is the stratum basale or germinativum is the other word that's used. So, and then, others like Marcelo Salpingian came in with this layer, this Malpingian layer, which is basically just the strata basale and spinosum put together. So the strata corneum, non-viable structure, usually it has non-viable keratinocytes. That's where we would find them. They've lost their nuclei, they've lost their cytoplasm, they are the outmost superficial layer. And then there's the lucid, the see-through structure in the glabrous skin, the palms of our hands, the sole of our feet, that straight, clear, lucid structure, strata lucidum. Underneath that is a layer where we find now our matured, keratinocytes. And these have cytoplasmic granules of this keratin hyaline. And this site specifically is the predominant site for protein synthesis. So underneath this is your stratum spinosum, where the the keratinocyte synthesized cytokeratin is found there, and usually it would accumulate in that layer in the tonofibrils, and all these bundles will heap up there in your hemidesmosomes. Then the last structure, which is the base, where your basal lamina is linked together by these hemidesmosomes, is the strata basale. That's where we actually find our melanocytes, and it is the only actively proliferating layer of the skin. And certainly, when we speak of proliferation, layers that have a high turnover, high mitotic count, that would be that. And it would fit in, as you'd see when we discuss radiation, how radiation actually attacks furthermore the cells that have a higher mitotic count. Now let's go to the dermis, the structure that's underneath, which accounts for 95% of the skin thickness. And this comes from derived from the mesoderm. It's divided into two: your papillary dermis and your reticular dermis. Papillary dermis, has more cells, and the collagen is much finer. And the reticular dermis, which is a deeper layer, has fewer cells and more coarse collagen. Now, there are more, layers in this, or other structures in this, because that's where we find our adnexal structures. Therein, the collagen fibers are there, the elastic fibers are there, your ground substance is there, such as your aminoglycans that are secreted by fibroblasts, which are produced by the collagen fibers themselves. And we also have a vascular plexus. We'll go more into it when we discuss the vasculature of the skin. And the appendages, of course, your hair follicles, your eccrine glands, which are the odorless ones with hypotonic fluid, your apocrine glands, more found in the axilla, in the groin, and this is where your odor comes from, and they usually start functioning from puberty. And your sebaceous glands that secrete this sebum containing, of course, fats and their breakdown products, your wax, esters, your debris, and this in essence is also bactericidal, specifically to your staphylococci and your strep, the sebaceous gland. Now, in that, we have all different shades of skin, and the Fitzpatrick's then classifies our skin layers, our skin colors, and gives us all the different tones. Not all, but a few, giving them to us basically with their ability to tan, and what usually happens when they are exposed to UV radiation. Now, what Fitzpatrick does is grade them from 1 to 6. I won't go through them all, but the fairer you are, the higher you are, up until you reach 4, where it's usually your brown Mediterranean skin, and then the dark brown and the black going lower down. These are the ones who tan easily and never burn, as compared to the utmost, which always burns and never tans. So when we speak of the blood supply, I'm going to be quick in this. The blood supply, basically, we've got 6 layers of vascular plexus. We get blood from the lowermost. It comes from the deep vessels. The heart gives off, the aorta, which goes and, gives off branches. And they go in different layers, from fasciocutaneous vessels, myocutaneous vessels, which are more predominant in the torso, and the main blood supply, and we get layers up until we get to the skin. So from there, we've spoken about the dermis, epidermis, and the hypodermis. Now, from the lower, let's go from bottom up. We've got a fascia layer that's under the hypodermis, and from that we've got a subfascial plexus. This is underneath the deep fascia. Then we've got, before that, on top of that, a prefacial plexus. And usually this is, more the predominant blood supply of the limb. We find it more, which is supplied by your fasciocutaneous vessels. Then we've got your subcutaneous plexus. Now this is at the level of the superficial fascia. You would know this is more dominant in the torso, predominantly supplied by these myocutaneous vessels. And then there's a subdermal plexus. So when we cut you, usually what accounts for most of the bleeding is this, as this is the main plexus that supplies blood to the skin. Then we've got the dermal plexus. The dermal, it's intradermal, in between the papillary and the reticular dermis. And then mainly those, are the arterioles, which are there for thermoregulation. And then we've got the subepidermal plexus on top, which is more for nutrition and thermoregulation higher up. And these are controlled, by different mechanisms. The sympathetic nervous system, the causing vasoconstriction, more the peripheral nervous system, causing your vasodilatation. And then you've got your humoral factors, which will cause vasoconstriction, such as your adrenaline, noradrenaline, serotonin, thromboxane A2, vascular endothelial, vasoconstrictive factors. All these things will cause vasoconstriction. And then the dilatation being the opposite, such as your bradykinins, histamines, prostaglandin E1, even acidosis, and instances where you have low oxygen and high carbon dioxide. These cause vasodilatation. And temperature in itself, heat is one of the things that will cause vasodilatation as a thermoregulatory mechanism. So these are some of the control measures for blood flow. Now, let's quickly cover wound healing. There are 3 phases, depending which textbook you use. Others would say 4 phases, grouping the first 2 of wound healing. And they usually happen immediately when you get injured. You then start this process. Stay not on injury. So the first process usually would happen for the first week, and then the second process will come in usually from the 4th day up until 3 weeks, and then the last phase usually from 3 weeks. And it may go on up until even 18 months, this being your proliferative, your remodeling phase. Let's start off with the first phase, which is the inflammatory phase. I'm going to divide that into 2. Hemostasis, then inflammation. Now, when you get injured, vasoconstriction happens. What causes vasoconstriction? We've spoken about it. The neural pathway, we've spoken about the humoral pathway. As you cut the cell in itself, the damaged cells will take out this thromboxane A2, prostaglandin F2A, adrenaline, noradrenaline, and this causes vasoconstriction. And the blood vessel in itself has this endothelin or endothelial derived contracting factors, and all of these will cause vasoconstriction. Now, after causing this vasoconstriction, we have platelets that are coming in. Of course, the collagen is now exposed, so platelets then go and bind to this exposed collagen and form a platelet plaque. Now, what will then happen is the clotting cascade is also happening. Remember, the Van Willenbrecht factor externally, factor 7 going in, and they go influencing factor 10, factor 10A, factor 1, which is prothrombin, to factor 1A, which is thrombin. Factor 1 takes on fibrinogen, which is, converted to fibrin. And all these fibrin strands, with the help of factor 13 coming in, cause a fibrin clot. So fibrinogen will then form this fibrin clot. And this is then your unstable, or this white clot that is there. Now, hemoglobin in itself is involved. Red blood cells then come into this area and come and plug on this clot, changing this color of the clot from a white thrombus to a red thrombus. Now, this is the phase of hemostasis. What also happens here is now that the blood clot that has formed becomes or serves as a for chemotaxis, and it will then initiate, and that's what they do. They initiate the next steps that will then happen. So with inflammation, that then comes in. Of course, by the way, mind you, there are many growth factors that are involved in this. We've mentioned just some of them, but there are more growth factors that are involved in this, such as your vascular endothelial, fibroblast growth factors, epidermal growth factors, etc. So now, inflammation is now the next step. So with inflammation, the endothelial cells, remember we had vasoconstriction, now we then get vasodilatation. The endothelial cells swell up, we get vasodilatation. And we said there are many things involved: your histamine, bradykinins, prostaglandin E, nitric oxide is involved, endothelial derived relaxation factors. So all of this causes vasodilatation. And if you remember the microbiology, with that you then get diabetes happening, which is now these cells that are able to migrate through the breaks and the interstitium and enter into the cells. So your neutrophils within the first 48 hours are the very first that do that. And neutrophils go in, and then after 48 hours, 48 to 72 hours, you will then get your monocytes, which come out and go into the tissues. What will this then do? Neutrophils, through the help of collagenase, they get out. They go there and they start the killing, mechanism. I'm using colloquial terms, but they kill cells, the debris that's there and the bacteria that's there. Macrophages are released through the chemoattractant protein 1 and are converted. These monocytes are converted to macrophages. And macrophages then assist also with the job of neutrophils of killing the cells, or the phagocytosis, and cleaning up the job. T lymphocytes are also involved in this. Usually we get them from about 5 to 7 days under the influence of interleukin 1, and they assist in wound healing. We certainly see that when they are not there, we really get poor wound healing. So the main thing, neutrophils, monocytes, which give macrophages, and then your T lymphocytes are involved in this. Now we move on to the next phase. The macrophages in themselves kick off the next phase, which will start off usually day 4. Remember we said the monocytes usually appear 48 to 72 hours. Macrophages then release growth factors, specifically your platelet-derived growth factors and your tumor growth factor. And these are chemoattractants to what? To fibroblasts. So then through this release, we are able to get fibroblasts that then happen. We are entering the phase of proliferation now. And in proliferation, there are, let's say, 3 things that happen: epithelialization, fibroplasia, and angiogenesis. Now, with fibroplasia, let's start off there, because that's now we are forming our granulation tissue, our ground substance. So this fibrin clot is replaced by, this fibrous connective tissue, and this will then become, our granulation tissue, which will serve as the bed for tissue repair. So what is mainly involved here is type 3 collagen. Of course, there are other factors that are involved, such as your GAGs, which your heparin, hyaluronic acids, etc. These are all involved in assisting to form this, call it amorphous ground substance, within which the collagen is deposited, because you need this ground substance. Then after we have that, as this is happening, we also having angiogenesis happening, which occurs concurrently with this in order to supply oxygen and nutrients to the wound. And how does this happen? There are growth factors which are involved. The endothelial stem cells migrate through the extracellular matrix. So we've got angiogenic factors such as your vascular endothelial growth factors, and these will then assist in the angiogenesis formation. Remember, angiogenesis is forming new blood vessels from currently existing ones, while vasculogenesis is the formation of new vessels completely de novo. They are being produced. The other thing that is happening is epithelialization. So you get these keratinocytes, which are present at the wound edges, and they then start to come together. We get them also from the dermal appendages, and they come together, and through this process of trying to reestablish this contact inhibition. And when that happens, then the process is then arrested and stops continuing. So in essence, that is wound healing. What will then happen after 3 weeks is that through these, the fibroblasts, start to mature into myofibroblasts. And remember, think of this as muscles that then pull the wound together. And then you also get, as the wound is contracting, the collagen in itself must strengthen and remodel. So that usually changes from your type 2 collagen, which becomes replaced by type 1. They become more organized, more aligned, and the ratios now start to balance, which is usually you'd get a ratio of 3:1. So if we take type 1 collagen, the ratio to type 3 collagen is usually 3:1, more of type 1 collagen. And the wound by about 3 months reaches 50% of its tensile strength, but will never regain 100%. Usually, in about 60 days, we are there where we've got 80% of tensile strength. Now, remember that the main thing about wound healing, there are terms that we need to get right, which is regenesis, or rather, which is repair versus regenesis. Repair, we are replacing like with unlike, whereas regenesis, usually in the first 6 months of life, like in fetal wound healing, we get more regeneration that is happening, which is replacing like with like. And it's interesting because you find that fetuses usually heal better. There's certainly a difference between adult wound healing and fetal wound healing. I mean, just from the collagen content in itself, fetal, you'd get more type 3 collagen, whereas adults is type 1 collagen. If you look at your hyaluronic acid, they are higher in peds or in the fetus, whereas they are a bit lower in the adults. When you look at the extracellular matrix, your MMPs much higher in the fetal than in the adult, and also your granulation would be much less in fetal, and the aggregation thereof is much less. And this speaks to the inflammatory cells because these are much less in the fetal wound healing process. Whereas in adults, there's many inflammatory cells. There's also more, that goes into this, such as your progenitor cells, which the number is found to be, quite inadequate. More, in adults, as you get the skin progenitor cells are found at much lower numbers to mediate a scarless repair, whereas they are better actually, the progenitor cells in the fetal, as they mediate a scarless repair. So those are usually your differences. The factors that would affect wound healing, it's something to know. There are local factors, which is oxygenation, of course, and that's caused by different layers, from vasoconstriction, decrease in oxygen, etc. And there are ways we can come in to assist. Infection, of course, a bacterial count more than 10 to the power 5 is a problem. Or if there's radiation, trauma, even a foreign body or denervation or edema in the area, it will affect. But of course, there are systemic issues. You divide them into, your congenital and your acquired. Congenital being your Ehlers-Danlos, your cutis lager, connective tissue disorders, in essence, progeria, Werner syndrome. And then your acquired conditions, such as, the older you are with age, diabetes, immunosuppression, your RVDs, and pharmacological issues such as your steroids. Smoking is a big one that I want us to have, and nutrition being a big one. Smoking, the most important thing is, there are 3 compounds which are usually the problem here: nicotine, carbon monoxide, and hydrogen cyanide. Carbon monoxide, we know it's got a higher affinity of oxygen, 240 times greater binding power, and so it would shift the equation to the left and impair tissue perfusion, which is what we don't want in smoke, in wound healing. And then hydrogen cyanide in itself, it's poisonous, it's cytotoxic, and it causes this intracellular oxidative histotoxic hypoxia that it causes there. Nicotine, it's in 4 ways. Let's remember that. 1, it's a sympathetico mimetic, so it behaves like the sympathetic nervous system, causing vasoconstriction, and that decreases tissue perfusion. It takes it down immediately as you smoke from 1 cigarette by 42%. Then it causes platelet adhesiveness. It increases platelets adhesion, and then you would form a thrombi. But also remember, it would increase your viscosity, making your blood much thicker, and this is usually as a result of the catecholamines that stimulates your platelet aggregation. So this becomes quite sluggish tissue, and viscosity increase is one of the risk factors for a DVT. And then the last way is the inhibitory effect it has on many cells that are involved in wound healing. What are those? Red blood cells. Remember, we said it assists us into making a blood clot. The red clot, your fibroblasts, your macrophages, and that's because of nicotine. Let's just touch on nutrition. Proteins are important. So if you've got your glutamine and your arginine that are low, it's going to be a problem. Your carbohydrates are a big source of fuel, so you want to be at an optimal level. Vitamin A, very important for collagen cross-linking. And so if you have a deficiency, you'd have a problem. Usually, you'd want your patient to have 25,000 international units per day. Per os. Vitamin C, also important because it's required for collagen synthesis, and so you'd want those to be at a good level. Vitamin E also as a membrane stabilizer, very important, including also your zinc, copper, and selenium, which are very important in wound healing. So I think we've covered most of wound healing. There are adjuncts to wound healing, which we will touch on in the other talk. Mainly your negative pressure wound therapy, your HBO, which is your hyperbaric oxygen, your ultrasound. There are many who also believe in electrostimulation as something that's believed to accelerate wound healing. Would look at that, to look at lasers, your low energy lasers, which are said to stimulate and excite the physiological process of wound healing, and your plasma rich plasma, your platelet rich plasma, one of the other things. And negative pressure wound therapy is one that we will look at as well. Thank you very much and have a lovely day. Bye bye.